We have cranial nerve 8, which is the vestibular cochlear nerve. It is done by Sanal and Becky. The anatomy of the vestibular cochlear nerve. The vestibular cochlear nerve is an afferent nerve. The cochlear part attaches at the inner and outer hair cells of the organ of Corti. The vestibular nerve portion attaches in the semicircular canal, the utricle, and the saccule. Collectively, they are called the labyrinth. As the vestibular nerve exits the semicircular canal and the cochlear nerve exits the cochlea, they meet in the internal acoustic meatus to become the vestibulocochlear nerve. It then travels to the junction of the medulla and pons. It will then continue to the thalamus and eventually to the cerebral cortex and cerebellum. The vestibular has 4 pathways: the vestibulo-ocular, the vestibular cortical, the vestibular cerebella, and the vestibulospinal. Here's a picture of the vestibular cochlear nerve. You can see where the vestibular portion attaches to the semicircular canal. The cochlear portion attaches to the cochlea, and you can see how it combines going through the internal acoustic meatus all the way to the junction of the pons and the medulla. This is showing you a picture of the pons and the medulla. You can see the arrow pointing to where the vestibular cochlear nerve is located.
So, the vestibulocochlear nerve has 2 branches, the cochlear nerve and the vestibular nerve. The functions of these for the cochlear nerve is responsible to transmit sound and audio purposes. The vestibular nerve is responsible for control of balance and sensation of equilibrium. The clinical presentation for cochlear nerve is hearing loss, deafness, poor hearing acuity. And for the vestibular nerve, the clinical presentations are vertigo, that is balance disorder, nystagmus, that is rapid involuntary movement of the eyes, balance problems, nausea, and headaches.
For specific clinical presentations of the cochlear nerve, if there's noise exposure, it can have a sensorineural damage of the organ of Corti. Otosclerosis is conductive damage at the middle ear ossicles. Otitis media, which is middle ear inflammation interfering with conduction. Cerumen impaction is a mechanical blockage of the outer ear, which also is interfering with conduction. Presbycusis is age-associated sensorineural hearing loss. It can be caused by trauma. Meniere's disease, which affects the labyrinth of the ear, causing progressive deafness and attacks of tinnitus and vertigo. Tinnitus is broken or damaged hairs on auditory cells.
So here are the clinical presentations of vestibular nerve. The first one is vestibular neuritis, or it's called as labyrinthitis. It is an inflammation of inner ear or nerve that connects the inner ear to the brain. So the chief patient complaints can be an acute onset of vertigo, nausea, vomiting, and complaints of imbalance that can last for 1 or 3 days. The next one is benign proximal positional vertigo, also called as BPPV. Most common cause of vertigo, positional vertigo, is a sensation of spinning with certain head movements. So the chief complaints for a patient presents is sudden onset of vertigo when head is moved, or commonly reported positional changes can include rolling over in bed or bending over. The next one is Meniere's disease, which affects the labyrinth of the ear, causing progressive deafness and attacks of tinnitus and vertigo. The next one is acoustic neuroma, which is a tumor on the main nerve from inner ear to the brain. The patient chief complaints is slow progressing hearing loss and can also have an ipsilateral facial weakness, tinnitus, and disequilibrium. The next one is cervical vertigo. The vertigo provoked by the neck posture, no matter what the orientation of the head is to gravity. The chief complaint for the patients is of unsteadiness associated with neck pain, limited cervical range of motion, dizziness, and headaches. And the last one is caused by the head trauma.
For the cochlear nerve testing, we looked at two tests. The first one is the Rinne test. The sound heard from holding a vibrating tuning fork outside each ear, which is considered air conduction, is compared to the sound heard by placing the tuning fork on the mastoid process, which is considered bone conduction. If bone conduction is greater than air conduction, there is a conductive hearing loss. In sensorineural hearing loss, air conduction is greater, but hearing is decreased in the affected ear. If someone has normal hearing, air conduction is greater than bone conduction in both ears. For the Weber test, a tuning fork is placed on the vertex of the skull in the midline. The patient states which side the tone sounds louder. In sensorineural hearing loss, the tone is louder on the normal side. In conductive hearing loss, the tone is louder on the affected side. In normal hearing, the tone sounds equal on both sides. Here's an example of how the Rinne test would be done. You can see where the tuning fork is placed on the ear for the air conduction and then on the mastoid process for the bone conduction. For vestibular nerve testing, some of the tests you can use are the head thrust test. It examines how difficult it is to maintain focus on objects during rapid head movements. The inability to maintain focus indicates damage to the inner ear. For the Hall-Pike maneuver, it distinguishes between peripheral and central causes of vertigo. The patient lays in a supine position with one ear down and the head extending over the table. The patient is to keep their eyes open. The patient is to report any sensations of vertigo. The examiner is looking for nystagmus of the eyes. You repeat the same procedure with the other ear down. If there is a peripheral lesion, the nystagmus is horizontal or rotary and vertigo is present, but onset takes a few seconds after the patient is in the position. If there is a central lesion, vertigo and nystagmus begin immediately and the nystagmus is vertical and changes direction.
This is a Hall-Pike maneuver test which we are going to do. Let's tell your patient to turn your head towards the right and come back. We are observing this for a sensation of vertigo as well as nystagmus. Here. Come back and repeat this procedure for the same side, other side.
Horizontal head impulse test tests the vestibular ocular reflex. The eyes are held open and fixate on an object. Starting at 20 degrees rotation off center, rapidly rotate the head back towards the midline of the body. While performing this, the examiner is observing the eyes. Caloric testing. This also tests the vestibular ocular reflex. Cold or warm water is instilled in one ear. It produces an asymmetric stimulation of the semicircular canal. The dynamic gait index is a measurement tool used to assess dynamic balance, gait, and risk for falls. While walking straight, the examiner will ask you to turn your head in different directions. The examiner is looking to see if you can maintain your balance while looking in one direction and continue to walk.
This is a dynamic gait index. In that, we are going to look for patient's balance. I will tell patient to walk normally with a normal speed, and then I will give them directions regarding their head tones. Alright, let's begin. Let's start walking with a normal pace. Okay, normal pace. Look up, look down, look towards your right, look towards your left. Alright, and keep walking, look straight up. And that's it. Alright.
The Romberg test. This is an exam of neurological function of balance. The patient stands with feet together. You ask the patient to close their eyes. The examiner is looking to see if the patient can maintain their balance. These are our references.